warm welcome to Medtronic Symposium 60, and we're talking about the objectives to understand the need of transcatheter replacement in the atrioventricular valves and the overview over the Intrepid program. And it's my great pleasure to chair this session together with my moderator, Azeem Latib from New York. We have an excellent panel here to discuss with. It's Bapat from the US. It's Thomas Modine from France, Bordeaux, and Lars Sondergaard from Denmark. So a highly experienced panel to discuss, and we'll jump immediately into the session. And I would like to ask Azeem Latib to talk about the audience interaction to keep this as an interactive session. Azeem, please.
Yeah, absolutely. Welcome, everybody. And thank you for joining us this late in the afternoon in Paris. It's so exciting to be here in person. But we really want these sessions to be as interactive as possible. We want to be able to answer your questions. There are microphones in the room. But if you're shy, there's also the chat function in the app. Please send us your questions. I'll make sure they answer your questions, no matter how hard or controversial they are. So I'm looking forward to that.
So we immediately start, actually, without any warm-up, and we will hear a pre-recorded lecture from Firas Zahr, who will tell us about mitral valve replacement with the Intrepid platform, feasibility in the Apollo trial, and beyond.
Well, good afternoon, everybody. It's a pleasure and honor to be with you all today in EuroPCR, although virtually, but hoping in person next year. My name is Firas Zahr. I'm an interventional cardiologist in Oregon Health and Science University, and I will be discussing mitral valve replacement with the Intrepid platform today. We will be discussing the feasibility in the Apollo trial and beyond. This is my disclosure slides. As we all know, the Intrepid valve is a conformable outer stent anchor that is not dependent on leaflet capture. It is symmetrical, and that eliminates the need for any rotational alignment. The valve has a circular inner stent that houses a 27mm tri-leaflet bovine pericardial valve. Currently, the valve is available in two sizes, 42 and 48mm. However, the 54mm valve is in development. The valve is the same valve that is used in the transapical system as well as in the transfemoral system. On the right side of the screen, you see the transfemoral Intrepid delivery system. It comes with a dilator and a sheath, and it is very similar to any other transfemoral devices that we use for mitral repair or replacement technology. It has a guide and an inner catheter that allow you to have a full free range of motion to achieve coaxiality on the valve. The valve can be seen after you deploy the brim, both on echo and fluoroscopy for both the mitral and tricuspid position, and that allow for very precise deployment. The valve comes in a single stage deployment, and we're gonna go through one of the cases so we can discuss the details of deploying the valve. The patient that we're gonna discuss is an 85-year-old gentleman with a BMI of about 25. He has symptomatic heart failure with a relatively elevated STS score, as well as frailty, especially at age of 85. He will be sized for a 48mm valve in the mitral position. And you can see his right heart cath data, as well as his basic echo data with mild degree of tricuspid regurgitation and mild RV dysfunction and a mildly abnormal LV ejection fraction. This is a baseline echocardiogram, both transthoracic and transesophageal, and you'll see that it's a very complicated jet, multiple jet, eccentric jet, and we were very worried because of the extent of the jet, as well as the eccentricity of it, and the fact that he had multiple jet, that we're not going to achieve adequate results with any transcatheter edge-to-edge repair. Therefore, we thought that he would be better served with the Intrepid valve. The etiology of his tricuspid, of his mitral regurgitation is 3B, and probably related to the tether, short posterior leaflet, which even make TEER more complicated. This is the neo-LVOT assessment using the cone method. And as you can see, despite the fact that there is a septal bulge, we were able to have a neo-LVOT area predicted at 1.8 centimeter square, which is enough for prevent LVOT obstruction after valve deployment. So we start the procedure by performing our standard transseptal puncture. In this case, we used a SLO sheath and Brockenborough needle. And all what we really need is to achieve the 4 centimeter above the mitral annulus, which is the standard in most of our mitral intervention. And then we placed a stiff wire in the left upper pulmonary vein, and we dilated the transseptal with a 14 millimeter balloon to facilitate the delivery system and the sheath into the left atrium. Following that, we then subsequently dilated the groin with the dilators, and we inserted a 37 French transfemoral sheath that has a curve at the end of it to help orient the valve initially into the left atrium. And then we removed the dilator, de-aired the sheath, and following that, we advanced the delivery system. The delivery system, as you can see here, the capsules comes out of the sheath get pulled back to the right atrium, and then the guide and the inner catheters are used to direct the capsule that houses the valve to be perpendicular to the mitral annulus. As you can tell from those images, simple maneuvers on the guide and the catheters help us direct it where we want it to be. After that, we deploy the valve by rapid pacing the heart via pacemaker, temporary pacemaker inserted into the right ventricle. And you can see the fixation ring that is extremely well visualized both on echo and fluoroscopy. We advance the valve in the capsule until we achieve the optimal position. And then we deploy the valve by advancing the capsule. And very quickly, within about 20 seconds of rapid pacing, you have a functioning valve with trace central regurgitation and no perivalvular leak. At the end of the procedure, we were left with about 10 millimeter ASD. And in this case, we elected to close the septum with a 25 millimeter cribriform implanter device. And as you can see on fluoroscopy and echocardiogram, we had a very good results on the valve as well as the ASD closure. At the end of the procedure, we had a very acceptable gradient of 2 millimeter mercury across the newly implanted Intrepid valve, with the valve very well seated 360 degree across the mitral annulus with full engagement of the anchors with the mitral annulus. There was trace, if any, central mitral regurgitation and no perivalvular regurgitation at all. And at 30 days, we have data on this patient. At 30 days, the valve is very well situated, exactly where we left it, with great hemodynamic results. So what we have shown today, that the procedure was predictable, was very familiar to most mitral operators, and we were able to achieve on-target valve deployment in reasonable time and relatively simple maneuvers, and we achieved no perivalvular leak, trace valvular regurgitation, and at 30 days, the implant exactly where we left it with no perivalvular leak or valvular regurgitation. So based on the results of this case and many other successful implants in EFS trials, the Intrepid transfemoral system has moved into the Apollo pivotal trials. And to remind everybody, with the Apollo pivotal trial that was originally started as a transapical approach, and now it's both transfemoral and transapical approach, with the primary cohort of between 250 to 500 patients, primary and secondary mitral regurgitation, with a primary endpoint of all-cause mortality or heart failure hospitalization at 30 days, or KCCQ improvement of 10 points or greater at 1 year. There is also a MAC cohort that is up to 300 patients, and that will also allow for the transfemoral system to be used in those patients. This is the journey of the Intrepid valve so far. We started with the first generation TA device in pivotal trial, and now we have the 35 French transfemoral system in the first generation transfemoral device that just finished the early feasibility and is currently in pivotal trials. And we are all patiently awaiting the 29 French system, as well as the large, the extra large 54 millimeter valve that is currently in development. And that will allow us to even have more anatomical expansion to include more patients in the transfemoral arm of the trial. What is also happening is that Intrepid device and the transfemoral system is being used for the severe tricuspid regurgitation. EFS and the FDA breakthrough designation has been approved, and the early feasibility trial for using the Intrepid valve in the tricuspid position is undergoing, with up to 30 patients approved at 20 sites across the United States. And we will continue to innovate as we all learn what is the best way to treat and implant the Intrepid valve in tricuspid regurgitation. The trial includes patients who are assessed by a multidisciplinary heart team and who have symptomatic severe tricuspid regurgitation, and they will all have to be suitable for the transfemoral access to implant the Intrepid valve, looking at the primary endpoint of implant or delivery system related SAEs throughout 30 days. Those patients will be followed up to 5 years in the trial. So in summary, the Intrepid mitral and tricuspid valve program continue to develop and evolve. Where we are currently is that the tricuspid early feasibility study is enrolling patients with severe symptomatic primary or secondary tricuspid regurgitation. And also the FDA has approved the inclusion of the transfemoral delivery system as an additional access to transapical access in the Apollo pivotal trial. Thank you very much, and hope to see you in person soon.
Thank you, Firas, for the excellent presentation and the heat up of the discussion. And we have now 9 minutes, which is almost as long as a presentation, to put some and share some light into these new options that we see here. And I would like to start with Lars, actually, being one or the first implanter of a transcatheter mitral valve implant. And if you see this journey that started about 10 years ago, we have now 20 years of TAVR, we have 10 years of transcatheter mitral valve replacement. What would be your key learnings? It has not taken off as fast, but we have had a lot of learnings, and I think we have seen a lot of iterations too. So this is basically now heading from the second generation to the third generation. What would be your key points in those 10-year journey to transcatheter, transfemoral mitral valve replacement, Lars?
Yeah. That's a good question. I mean, I think we were maybe a little bit naive when we saw the first devices coming out and thought we couldn't replicate what we had seen in the aortic side. It would be an easy journey to get it out into clinic. I think we have seen it's very complex. The mitral valve is much more complex than the aortic valve. There's a lot of adjacent structures we also have to take into consideration, particularly the left ventricular outflow tract. It has so far been difficult to develop transfemoral, transseptal techniques, as we have seen here, which is coming a long way forward. So most of the procedure has been done as a transapical approach. And remember, we are treating quite elderly patients, frail patients. Most of them have secondary mitral regurgitation with impaired LV function. So doing a thoracotomy in these patients, doing a big hole in the apex, with the risk of bleeding and myocardial injury has also been a kind of a limitation for this technology. So I certainly think if we need to move it forward, and it is moving forward now, we need to have good screening of the patient, select the right patient. We need to have a technique which is minimal invasive. So as I said, it needs to be transfemoral, transseptal to open up for more patients. And I think finally we seems to be very close to where we hoped to be already 10 years ago.
Okay, before we deep dive into the Apollo trial, we have two colleagues from the US, which is Azeem and Vinny. So, Azeem, if you look into this perspective, so one of the situations that was always the goal for the therapy was to have one simple answer to all complex valves. Is this true? Can we go there? Will this be the 5-year goal now? Will we reach this earlier? What is your impression with the development of so many innovations in the recent years and with this valve support that we have there, Azeem?
Yeah, that's a great question and something we all like to discuss, and we like to talk about, needing a toolbox for the mitral, because I think we've realized that this valve is so much more complex than the aortic, and there's not going to be one single device to treat every anatomy in every patient. I think more and more, even though it's been a long road with TMVR, we really realize that we need valves too, and they're going to form an important part of the toolbox. There's so many patients we see on an almost daily basis that are not good candidates for edge-to-edge repair, either because they have small annuli, they have multiple jets, like you see in this case, with very complex mechanisms of their mitral regurgitation, they have annular calcification, they have calcium in the leaflets, and those patients can't be treated well with edge-to-edge, so we do need a replacement technology. Now, there's lots of replacement technologies. At one stage, I think I lost count, there were about 36 companies working on a mitral valve replacement technology. I don't think we need 36 mitral valves, though. I think we need a few. How many there'll be in the end, I'm not sure. But it's clearly becoming apparent that the ones that will be there long term need to be, for me, transseptal, need to be able to treat a wide range of anatomies, including treating patients that have calcium as well, either on their valves or on their leaflets. I think this technology distinguishes itself from some of the other mitral valve technologies, and Vinny's probably the best person to speak about how many patients get selected for this. But when I look at different technologies, we try and think about what are the differences between the technologies. Some of the differences that come out when you think about Intrepid versus other technologies, well, one, it doesn't go over a wire, which initially, when you first see that as an interventional cardiologist, it leaves you a little bit concerned because we're so used to implanting everything over a wire. Yet we've seen from some early technologies that having wires while we're implanting valves leads to complications and leads to perforation, so maybe we don't need a wire. And I think the other part that really stands out for me is the mechanism with which this valve anchors. So it's not using ventricular anchors to anchor on the leaflets. It's a single-stage device, so you don't need to put an anchor first in order to then deploy the valve. The valve deploys and anchors on the leaflets and the annulus, which I think has certain advantages, both from an anatomical point of view, but also from an imaging point of view. The imaging required for this, and we'll see this with tricuspid as well, is certainly less complex than it is with some of the other technologies.
Absolutely, great points. So in the center, we have 3 interventional cardiologists, but on the outskirts, we have 2 heart surgeons.
The goalkeepers.
And we shouldn't, the goalkeepers, but
we deliberately put them on the end, so they keep control of the table.
So we cannot expand too much to the side. So I start with my right side first, because Vinny is deeply involved in the Apollo program. And perhaps, Vinny, as a heart surgeon, it is, of course, a complex situation that we moved away over the 20 years away from transapical TAVR. In the beginning, I know all the discussions in the Gary registry in Germany, of Tommy Walter, where he said we have to do 50% of all procedures transapical in TAVR, and now we have a class 3 indication on transapical TAVR, and we almost exclusively do TAVR implants conscious, transvascular, transfemoral, and sometimes subclavian. And they're incredibly stable. And we've come down from a 30-day mortality of 10%, or 9 to 10% in the very early days with snaring every month, down to a robust routine procedure with a mortality that is now around in Germany 1.5 to 1.9%. And with a volume in Germany of 21,000 TAVRs per year. This is 75% of all aortic valve implants in Germany, replacements. So what is your impression if you see the pathway that, of course, we had to have the innovation first? We had very large bore sheaths in the beginning. We had to use the apex. But what is your impression if you see the handling of the patient, also the patient outcome in the transition from transapical Apollo experience, which is the largest, we have still to say this, to almost the same size in transfemoral, and the perspective to go down from 35 French to 29. So what is your perspective and how is the data? We didn't hear so much data about Apollo. So how is the EFS situation and the mortality improved by moving from transapical to transfemoral? Vinny?
I think, thank you, Stephan. First disclosure is I'm a surgeon, so surgery is still gold standard, and including for aortic valves. But to be, this aside, I think we have learned things for sure. Is first of all, direct approaches are always better because they first tell us about does the device work very well. And I think what we learned in the early global EFS, which is first 50 patients ever, not only the device worked very well, but we also learned that our screening worked very well. And I think Lars alluded to the point about LVOTO. I think we learned a lot on that. Now, the second natural step, of course, is can we make this less invasive? I like surgery, but if we could deliver this transseptal, I think that is always going to be better for the patient. We have learned now from co-op trial and mitral FR that this is also, if you look at any mitral trials and the patients we are enrolling, 68-70% are patients with secondary MR. These patients have ventricular disease. So if we avoid touching the ventricle, it's obviously going to pan very well for the patients. I think being cautious about this approach has paid a lot of dividends. For example, without disclosing too many results, which unless they are already out in public domain, when early EFS data was shown by Dr. Zahr, there were a lot of zeros in terms of mortality, in terms of device displacement, in terms of valve thrombosis, because luckily and fortunately, the early 6 years have been invested very well in this technology. So I think we are paying those dividends and we are building on top of that now. And the transfemoral cases, as you saw, have become, I would say, not routine, but predictable. And this is exactly what you want when you're doing the case or expanding, say, to Apollo Europe or other sites, that you want it to be predictable. Going back to TAVR, TAVR has become a commodity, as Stephan said, but I hope most people in this room don't forget 10 years ago what we were doing. It has become because one is the French size has gone down and imaging has become better. So just imagine if CT imaging wasn't there, we probably will be doing a lot of these patients still under GA with TE. I see a slow transition towards something similar in mitral, but maybe we'll still need good imaging. But I think less invasive approach is here to stay now.
Okay, this leads directly actually to your presentation, Vinny. And we also have to remember that mitral valve disease is not only pure regurgitation, but we see other disorders. We have hypertension, we have calcification, not only of the leaflets, but also of the annulus. And this can be dismal actually for some surgical approaches. And we know that ventricular rupture is one of the downsides of actually implanting a valve replacement in a heavy calcified mitral annulus. And perhaps you can give us some insights about MAC and mitral valve disease and how this impacts where to actually address the valve disease. Please,
thank you,
Vinny.
Stephan. These are my disclosures. So I think experience of most surgeons in this disease has not been the best. I think we know
Can
that...
we get the slides, please, of Vinny? The central screen. Thank you.
There you go. So I think when we say technically challenging, technically challenges can be many, one being inferior results, bleeding, LV annular disruption, but also implanting a small functional valve in MAC is not uncommon. So TMVR in general as a therapy can provide a really good option. And as we know that long time, off-label, we have used balloon expandable devices and even some devices such as Lotus in these patients. This gives us an opportunity now as we are screening more elderly patients, that can we use dedicated TMVR devices for the same indication? Firas has already alluded to this, essentially transapical recoverable system to transfemoral delivery system. So I'm not going to go into the details of it. But I think a whole idea is if I can do this less invasive in a predictable way, obviously transfemoral system is, or the delivery pathway is going to be my preferred pathway. So again, the TMVR transfemoral study overview, again, Firas has gone through it, so I'm not going to go into the details, but essentially the criteria are MVAR criteria which we follow, with a screening committee as well, which oversees which patients are enrolled. The baseline characteristics of these 3 patients on early experience, what we did was not only looked at all the patients with MAC, and MAC can be a very heterogeneous cohort. As we know, what is MAC? Is it just presence of a bit of calcium, or how much calcium we should call it as MAC? Is it circumferential, commissural, distribution, thickness? We can go on about it for all day. So we decided that in the early experience itself to go through all these patients and essentially divide them into 3 categories, if I may, green, orange, and red, and then slowly expand the indications cautiously so we understand how the device interacts with this MAC. These 3 patients were the one which we have experience with. You can see again the age is essentially quite elderly. STS risk is pretty high. And you can see the device sizes have varied from either 48 or 48 in all the patients. Again, this is quite important because many MAC patients we see clinically tend to have very small annulus. Patients' EF was reasonable in these, and MR, of course, was moderate or severe, or moderate to severe. And these are just, in general, the dimensions. I'm going to highlight the LV dimensions here because if it's a pure MAC with stenosis, it's a possibility that the LV is quite small, and that may have implications on how the LVOT prediction is going to work in these patients. But since these patients had also significant MR, the LV was reasonable size. You can see again that all these patients do tend to have RV dysfunction as well. From early clinical experience in MAC in surgical and non-TMVR devices, we know that these patients inherently are slightly different than those patients just with mitral regurg. This is just to highlight what the degree of MR was, and also the stiffness of the annulus and the leaflets, if you can see, especially in patient 3. These are just snapshots of CT. This is just to again indicate, how we classify MAC in terms of the green, orange, and red. There are some MAC classifications at present, especially with balloon expandable devices. And I think in future, eventually, I think all the devices may have to add up to a certain score to see what works and what doesn't work. It's quite common sense that looking at this device, you would want some annular interaction. So if you look at the nature and distribution of the MAC, this is, I think those surgeons in the audience will think like it's like a surgical ring, so to speak. And then again, in some patient, of course, in one, we had some anterior device as well. As you have seen again in the case Firas showed, the transseptal delivery system, one good thing about this delivery system and approach, if you have missed it in that presentation, is the puncture height is 4, and by the time you maneuver the capsule and open the brim, you are not that far from the target. So if you have achieved a good trajectory, you generally get a really good position just with slight manipulation of the delivery system. And this, I feel, although I'm a surgeon, that this probably is more stable than my hands in achieving a good coaxial deployment of the device. And here you can see that not only it is well controlled, patient is stable. You can see in this particular patient, the MAC, which is there on the posterior annulus specifically, and then the device is deployed with the help of fast pacing. And then, of course, retrieving the capsule, and then a very stable device. 2 schools of thought when we started this early is actually calcium might help the cork shape, as you can see it in the right side. And on the other hand, we were a bit apprehensive as well, whether presence of calcium in the annulus will reduce the cork function, which is, the annulus contracting with systole and holding the device. So we feel quite confident now we can grow this experience in the right direction with such results. This is just to highlight how the SAPIEN looks like in the patient 1. This is the post-implant CT, and you can see that the outer frame lives up to its reputation of conforming very well with the annulus. Again, this is not uncommon in MAC that you have rigidity of the annulus, especially in the AP or the SL dimension. And also you may have CC dimension, which is a bit more eccentric. And you may have an aortic device anteriorly as well. And the outer frame really conforms very well. And you can see that the inner wall, which is 27 millimeter, despite the AP reduction to 28, the inner wall is fairly circular with no regurgitation through the valve. So procedural results, successful implant in all 3 patients, minimum gradient, not surprising again because the inner valve retains its shape. And more importantly, maybe anterior MAC is a bit protective because it doesn't allow the device to expand into LVOT. I think the LVOT peak gradients and mean gradients were not spectacular at all. 30-day clinical outcome, these all patients survived, and there were 2 patients who we have highlighted here with major bleeding events. These were essentially groin hematomas. We have learned recently all these things mainly happen because of aggressive anticoagulation, which we used to do from day 0. Recent investigator meeting, we have corrected that. Most of us now tend to start it on next day. There are some other protocols in place now to make sure that there's no groin hematoma, which leads to essentially blood transfusion and which gets counted as a life-threatening bleed or major bleeding. As again alluded by Firas, Apollo pivotal trial has a MAC cohort now. You can see why this cohort has been included in this. A lot of these patients don't have a very good option. I definitely probably will hesitate in operating an 84-year-old with MAC with open surgery. And I think these are the ideal candidates to go into this cohort. And we are going to see with the same primary endpoints at 1 year how these patients fare. To summary and conclude this presentation, we have now started treating patients with MAC. Indeed, this is challenging. We need to understand how specifically this device works with patients with MAC. There are other devices which we have used in MAC. Each device may have a different flavor, different strength and weaknesses. And I think the whole idea of this is, again, cautious enrollment into this trial so we get the best benefit of our patients. And I think the 30-day outcome for 3 patients I have already presented. There have been no strokes as well, which is critical. Some devices we have used in MAC had slightly higher incidence of stroke than non-MAC patients. So I think this is extremely encouraging. Thank you.
Thank you, Vinny. Join the table. I think we can continue with some of your conclusion remarks, and we have some interaction online now from New York, actually, with a German being in New York. And this corresponds very well to the situation about anticoagulation. I would like to start with that before we go more into the access route. We know that those patients are highly at risk with MAC. So, Azeem, before we go to Thomas, what do you think about the anticoagulation, and what about cerebral protection, and especially this subgroup? What would you say? What is the perspective there? What would be the rule of thumb that we would develop? Of course, we don't have the massive data there yet, but what would you say and think about when to start anticoagulation? Do we need oral anticoagulation? Everybody? Do we need it half a year, 1 year? What do we do with the MAC patients if we deploy such a stent or if we predilate those patients? Do we need cerebral protection in those situations?
Yeah, sure. I think they're both interesting questions. I'd love to hear from Vinny as well, from the study and what the study recommends. But generally, for most of us, I think, irrespective of the valve type, particularly with these larger valves, we've felt that anticoagulation is really important after the procedure and long term. How long? I don't think anybody really knows. We need to do the studies to understand will people need to be on anticoagulation the rest of their life. But I think for now, we realize that the risk of thrombus on the leaflets or the valve is real, and so we need to prevent that. As far as the cerebral protection, again, very little data. Certainly when we do valve in MAC with balloon expandable valves where the amount of trauma on the annulus, often because we're oversizing and the amount of opening force is large, we tend to protect their brain. No data to say we should or shouldn't. I'm not sure with a self-expandable valve like this you need to do it. And when I see how low the stroke rates have been so far, I'm not sure it justifies the cost, but I think it's still an area that needs a lot more research.
Yeah, to you, Vinay. What about the Apollo experience? The subarm, it's a single arm in Apollo, the Intrepid and MAC. How is the situation, the experience there?
I think, again, as I said before, screening has played a very important role. For example, we are not including at present patients who have, say, exuberant MAC, which is protruding in the lumen. But surely with time, we may think about, that cohort as well. Coming to the most contentious point or under discussion is, should we balloon these patients? And I think not only with SAPIEN, with Tendyne experience and few others with MAC, can you make the place where you're going to implant the valve, the seat of the valve, bit better? And I think there have been a lot of conversations around it. The interesting thing is you want to balloon it, but the biggest, say, true balloon, for example, is 28. So, are we really going to make a difference? And then can we use other type of balloons in this, like Innové balloon, for example? So I think there's a lot of conversation around it. I think next year will be wiser. I think in general for the TMVR MAC patients is if we do balloon, does it move the calcium? But as a surgeon, when I've deployed it with balloon expandables under vision, it definitely circularizes it better. So I think if I may say recruitment of the commissioners is better in eccentric annulus, sure. As far as anticoagulation, I think initial thought was, reverse the protamine, start with heparin, next day start anticoagulation. Some centers did start anticoagulation on the same day. When me and Thomas do a mechanical mitral valve, for example, in a patient, we start warfarin next day. We don't put them on heparin. And warfarin climbs slowly over 5 days to a therapeutic range of 2.5. I think slowly applying that knowledge cautiously, we are now not doing heparin transition. We are starting warfarin next day. I think that will reduce that groin complications which we saw, and at the same time not pose any threat to leaflet thrombosis.
But what about the Apollo protocol? So there are two different approaches at the moment, and one is going into warfarin. A lot of trials on transcatheter valve replacement, and perhaps both of you can answer, really involve at least warfarin for half a year as a minimum. Yeah. It can be extended, but some also add a single platelet therapy to it. So this is mostly aspirin plus warfarin. Is this the way to go? How is the Apollo experience here? Because you always have two arms. The leaflet thrombosis doesn't appear immediately, as you said. So there may be an interval where we should be more cautious directly after the procedure. And this can only be 4 or 8 hours or whatever. Do we have to load with aspirin IV immediately? Do we have to do all these things, or do we do them next day, or do we leave out the sept in addition to oral anticoagulation as a whole? So there are many protocols in many devices. Perhaps you and Vinny before we go over to Thomas.
Yeah, man. First of all, this patient is of course at a high risk for thromboembolic events. Most of them have atrial fibrillation. They have a huge left atrium with sluggy flow, and they have the big valve sitting there. So that's a high risk. On the other hand, we have seen that compared to the patient you're talking about, Vinny, who got a mechanical valve, which are younger and less frail, that these patients will tolerate it. These patients may not tolerate a very aggressive anti-thrombotic therapy. We have seen the data from the TAVI space that less is more here. If you're too aggressive, the patient is going to die from it. So we need to learn more about this and find the right balance for each patient with regard to anti-thrombotic therapy.
Absolutely.
There's only one patient who had a GI bleed, and I completely agree. I think at least my simplistic view as a surgeon has always been cardiologists were used to stents. TAVR was on a stent, so they got all aspirin. Nobody challenged it, and now we are extending it to everywhere where it is stent. Maybe actually we don't need antiplatelet, we just need anticoagulation.
Absolutely.
Maybe that's the way to go.
So, taking the view that we had on the US a little bit to Europe, Thomas, do you have anything to look into the future? Are there some changes? Can you give us an impact on what is the future now, please?
I mean, there's no secret that mitral regurgitation is a highly prevalent and is obviously a heterogeneous disease. I'm very happy to hear that my cardiologist colleagues have changed their mind, because in the last few years, and Vinny knows about this very well, there was only one technology, one solution to treat mitral regurgitation. So everybody changes, and I'm very happy that my cardiologist colleagues are changing. And the reason they are changing is it's not because Vinny and myself have been convincing. It's because, I mean, they are finally looked at the evidence, and the evidence is that we have much more mitral valve disease than aortic disease. And there is a huge number of patients which are very different, with a lot of variations anatomically. So you have, even within the mitral regurgitation, you have the functional and the degenerative one, but also when it's degenerative, you have a P2 prolapse, P2A2, you have the clefts, some of them doesn't have, you have a long chord, you have short chords. And I mean, just from this perspective, and this is why it's also nice that the cardiologists come to the operating rooms and look at the anatomy of the valve. I mean, it's impossible, except if your name is Latib, Van Bardeleben, or Lars Sondergaard, to imagine that a transcatheter edge-to-edge repair could be applicable and could be optimal in all the patients. So only reasonable minds can say that we need something else. And this is why the future is now. It took us some time. So, I mean, the first mitral clip has been done in 2003, correct?
Yeah. Correct.
The first in-human transcatheter mitral valve implant has been done by Lars in Copenhagen in 2012. So, and then we were not happy with the results, and we all admit that. But we were not happy with the results also because the technology was not mature enough, was not adapted enough at that time. And even in less than 10 years, we have made a lot of iterations, and new generations of devices have shown. We must not forget that we had all the programs of replacement have been slowing down, waiting for after the Mitra FR results, and also waiting for the COAPT. And even Medtronic program has been slowing down because they said, okay, if COAPT is perfect, we're gonna treat everybody like this. But this is not good. And this is why we're here today. So the journey started back in 2014, and now we are in 2022. And I mean, you can see here that the clinical program for TMVR within Medtronic is under heavy investigations. And you see that, and despite that, now more than 350 patients have been treated so far. And we have up to 6 years follow-up. Some patients have been treated 8 years ago, and they still doing very well. I mean, this slide, you've seen it. This has been shown by Firas, and I'm not going to spend a lot of time on it. So we are investigating today the transfemoral and the transapical approaches. We have some roll-in patients. We have different endpoints, of course, and we are looking at all cause of mortality, not only cardiac disease mortality, and this makes sense. However, I mean, I think it's very important to consider the population that we are treating today. We have done with Stephan and Sebastian here a large registry that we have conducted, and we have more than 700 patients that have been collected. I mean, it's like TAVI in the early days. The Euro scores are not capable to capture the severity of the patients we are treating. So we treat them, we have sometimes very good results, we see it here, but they will die 1 year or after 2 years. But this doesn't mean that the therapy is not good. They could die from something else. And Vinny has been saying that we have to be very careful about the selection criteria and the patient we enroll, because we want to be sure that the replacement to the Intrepid is the appropriate way to do this in comparison with other technologies, and keep the options open. So let's look at this first. So Intrepid TMVR pilot and Apollo roll-ins together. If you put all the numbers together, I'm going to show you some results, more than 200 patients. So this is a very big, the largest replacement data that you can have. We have almost a 2 years follow-up. I'm going to show you the clinical outcomes and some of the paired echo data. We're not going to discuss everything, of course, today. But that's it. I mean, patients are not too old. I mean, they are not as old as with TAVR. And we have more patients which will be younger. The majority are male for some reason that we don't know really. The STS score is very high, so patients are really very severe. All of them were moderate or more mitral regurgitation. They have COPD. They had an impaired ejection fraction, as you can see it here. In 1/3 of the patients, they have an associated tricuspid regurgitation. And we know that isolated tricuspid regurgitation is a bad prognosis factor. So this is something also that we have to put and keep in mind. 10% of them had a prior valve surgery, and more than 60% of them, they had associated AFib, which explain also the need for oral anticoagulation after the cases. So the mortality was very acceptable in this high-risk population in the short, early period after the implant, and then it grows. It goes up to 26% and then 37% at 2 years. And this is what I was saying in the beginning. I mean, we could not blame only the therapy itself. There are some other comorbidities, some other factors that are misleading us and that we have to understand and probably analyze the effect of this therapy independently. Is it effective? It is effective. The first thing we are treating is a patient, and we treat a patient who comes because he has a shortness of breath, and he has been admitted once or 2 or 3 times for heart failure. So you have 2 choices. I mean, you keep him like this, or you treat him. And if you treat him, you want to see, in addition to the effectiveness on echo, if he has a better quality of life. And he has a better quality of life because he breathes much better. And this is reflected here up to 2 years of follow-up. You can see it. I mean, the majority of them are NYHA class 1 or 2. And I mean, even in the mitral FR patients, we have seen that they are in many of the patients, they have been doing better. We should not, and we must not forget that. The valve durability, as I told you, some patients are now beyond 5 years follow-up. So we have positive signs of durability. I hope it will continue. We want to go beyond 10 years at least, of course. But this effectiveness of the therapy is long-lasting. This is good. So if you don't have a powerful leak in the beginning, and there's no reason to have it, if you don't have a central leak and there's no reason to have it, if the result is good in the beginning, it's long-lasting. So remember, one of the problems with the other alternatives is how long it will last. Ralph, we were in session on replacement before, and Nico Piazza has been trying to push him. And after 19 years of MitraClip, what is the durability of this therapy? 19 years. We have 4 years, 5 years. So in summary, for the Transapical program, I think the Intrepid pilot study and the Apollo roll-in demonstrates a stable valve function and improvement in mitral severity in high or extreme risk patients. Okay, so let's go to the transfemoral. I mean, Firas also alluded to that in his presentation. So this is a prospective multi-center, non-randomized early feasibility study. I think it's very important to understand that one of the big differences between the population that we are treating with the TMVR and the edge-to-edge is the access himself. And the access, I think, has a great impact. I mean, you do a dental surgery, it's very invasive. So imagine a thoracic surgery. And if you look at the data and literature from digestive surgery, extrathoracic surgery, the invasiveness plays a role in the recovery of the patients. So I see no reason why it's not the same here. So the core lab is at the Mayo Clinic for the echo, and of course you have an independent CEC adjudication committee. So this transfemoral early results of patients, again, they are at high risk but lower risk than the transapical one. So you have a more invasive approach, higher risk patients, less invasive approach, you implant lower risk patients. The majority of patients, and this is very a turn, I would say, in the enrollment, we have much more primary MR than functional MR. But if you look with other results, with the transapical one, with other valves, we had much more functional mitral regurgitation, and this is a good thing also. They all have been in moderate or severe tricuspid regurgitation, high percentage of atrial fibrillation, hostile chest, so still they are very happy. Interestingly, and I mean, luckily, but this was not a surprise, no mortality at 1 month, no stroke at 1 month, no need for re-intervention at 1 month, no pacemaker, of course. We had some MVARC bleeding issues, but I mean, we told you, and you've seen it probably, that the sheath is too big, but we are all waiting for the new generation of sheath, which is smaller, that could, and also the management of anticoagulation. It's still very effective, the transfemoral approach, and you can see it here at 1 month, there's no mitral regurgitation. There is no other alternative to replacement to treat mitral regurgitation that have been able to reproduce or to reach this efficacy. So this is very important, and we're still very efficient also clinically. The patient get the benefit even better than with the transapical approach. See that there is no red numbers for NYHA at 1 month. So in summary, the 1 month results from Intrepid TMVR, transfemoral demonstrate no mortality, no stroke, no re-intervention. Half of the patient had major bleeding. I mean, honestly, it's very, very big, but we're getting smaller. I mean, when I did my first TAVI back in 2007, the core valve sheath was 25. So we almost divided by 2. You know, we used to have more than 50% of mortality, and no one was criticizing, you know, except surgeons, of course. But I mean, look where we are here today. So give it some time, give it some space, and that's very important. And the FDA has approved the transfemoral delivery as an alternative approach for Intrepid TMVR, and now it's enrolling with the Apollo. So I've been saying that we have started investigating this therapy a long time ago now. We are approaching the 10 years. And I'm very happy to announce that in addition to the randomized control trial, to the Apollo American trials, they're going to be a European trial, and the CIP has been submitted today in France, tomorrow in Germany. And we are very thankful for Medtronic to explore this therapy in our European patients. It's not that it's not enough from US, but I think we all have our contribution to give to the field and the therapy. So I want to start by the end of the slide, because we are very proud to say also that we are the co-PIs of the study. Lars is in the steering committee with us. So we going to, I want to say that this European trial is capitalizing on the experience that have been generated and accumulated from the US experience. As Vinny has been saying, more than 350 patients have been treated now with Intrepid. So this is a consistent number. We have up to 6 years of follow-up with the results, which are very encouraging, I would say. The transfemoral access has been added to the Apollo trial, including for MAC patients, and I think the access will play a great role in the improvement of the results, not only on short term, but also at 1 year and 2 years, and this is what we want to achieve. And hopefully next year we start talking more and more about the patients that we are enrolling in Europe. Thank you very much.
Thomas, join us, and it's an important message and it's important data that we see here for the discussion. And Thomas has joined the first mission to the moon, not the Chinese mission to the moon. That's also a very important message here. What about the consequences actually of this transition? And actually, if we see the large field of all devices, we have experienced not only on the mitral valve but also on the tricuspid valve that actually we're nearing TEER mortalities at 30 days at least. We have to see how the long term is, but if we look into TEER and tricuspid and replacement in tricuspid, we're also in the range of 0 to 3% mortality in also large bore devices, transvenous, which are also around 30 French. So there may be a side bleeding. But first Lars, perhaps, and then Vinny. What is your perspective? And short, because we're running or we're going at the end of the session. What is your perspective into the situation coming off the high-risk patients that we have treated in the early EFS and, of course, compassionate use? It's always sick old patients. We've seen the STS score, the Euro score, etc. The age was 74. The age increased in the EFS and this also in the transfemoral EFS. Increased by 6 years, but the mortality dropped from 13% to 0. Smaller group, of course, only 15 patients versus 200. We still have to see the perspective there. But what is your perspective on the treatment? Will this have an impact on the treatment?
Maybe just as you answer that, just think about this. There was a question from the audience as well. Similar, because you showed on your slide, Thomas, a 38% mortality in 2 years. And so people look at that and they go, oh, wow. Would the mortality be the same if we treated the patient conservatively or not? So maybe as you respond to this, just if you could respond to that comment too.
So first of all, I mean, one of the arguments for doing a valve replacement instead of a valve repair is that it's more efficient. On the other hand, it's more safe to do an edge-to-edge repair. We have seen that now, at least in a small group, it seems to coming down to close to what we have in edge-to-edge repair, which is not 0 or 30 days. Yeah. And also remember, when you look at the mortality, the 30 days mortality is going to reflect the safetiness of the procedure. What's happened between 30 days and 1 year is much more reflecting the profile of the patients. And that's why you see a mortality rate close to 25% at 1 year. That's nothing about the procedure. It's about the patient you're treating.
Exactly. So what is the perspective? What patients are we aiming for? How will also the data change? We have also seen changes in data in TAVR. So the early days had horrifying 1 year and 3 year mortalities. Now it's standard therapy that has very good results also on long term.
I think we have learned that as well. Early TMVR experience, Lars will remember this very well, is we're treating patients with 20% EF. We have become wiser now. Just that one factor has changed. Patient selection, safety profile, most important. That has increased with standardization of procedure, good screening, delivery systems going down. I think that we are nearly there. I think we need to also remember that TEER at present is approved, but if say we do a TEER and it doesn't work, the only option becomes surgery. So I think as we make these devices safer, transseptal, there's going to be a more swing and confidence in including those patients in TMVR, transseptal, and I think we are getting to that point now.
Absolutely. So I'd like to conclude, and I would thank the whole panel. I would thank all speakers. I think we have shed some new light into a very innovative treatment option, and I would say that this is an extension of the toolbox. So in the beginning, the therapy will not be the therapy for all, but we have an option for those patients who may face a less good result in a TEER situation, which is an established and safe procedure with a large patient volume. We don't have to forget that. So in the last 10 years, there have been more than 100,000 patients treated. We are also seeing that the volume here, and we're seeing 350 patients being treated, has also increased only in the last years to dramatic numbers in the trials in Apollo. We see as a conclusion that also the European population is now benefiting from this therapy in a trial. So we have the Apollo trial in the US, we have the Apollo EU trial now with about 30 sites in Europe contributing to a common knowledge in a large patient scale, which will exceed 600 patients. So I think this is a very important message. And we've seen that the move from transapical within the therapy, first with almost the same or with the same sheath size, going from transapical to transfemoral, has definitely dropped 30-day mortality. We hope to see this also in the ongoing trials, which will be single-arm trials first and then randomized trials in a large set of patients. And I think there is growing evidence and growing knowledge about these therapies. So perhaps, Azeem, if you also want to give one final comment.
And we shouldn't let the tricuspid become the forgotten valve again. So let's remember that this technology is also being evaluated in the tricuspid. There's a EFS underway right now to really understand how Intrepid will function in the tricuspid space. The initial patients done show really excellent outcomes with really obliteration of the TR. I think there's been a 100% success rate so far, but there's still a lot to learn again about patient selection, the procedure, and patient management.
Absolutely. So you can never tell me that I forget the tricuspid valve, Azeem. So the same pledge is to the company, of course. So I think we have an option, and this is the title of the session. It's an option for atrioventricular valves, and this compromises not only the mitral valve, but also the tricuspid valve. And we're looking into the future, but the first steps we see here will be on the mitral valve in volume. So I would like to conclude the session in time, and I thank you all for being and attending this very nice session in Studio A of EuroPCR 2022. Thank you very much.